Hello, my name is Paul Riley from the scientific marketing team at Diagnostica Stago, covering the US and Canada from our US headquarters in Parsippany, New Jersey. In recognition of the critical role hospital pharmacists play in our healthcare system, Stago is launching a new educational scientific short video on YouTube taking place during National Pharmacy Week starting Monday, October 12th at 12 p.m. Eastern Time. The title of the Stago scientific short video is Direct Oral Anticoagulation, or DOAC, Agents in the Management of Pediatric Venous Thromboembolism, or VTE, and will be presented by Dr. Blessy Phillip. Dr. Blessy Phillip, hospital pharmacist from Baylor College of Medicine and Texas Children's Hospital, joins Stago for our special educational video on the breaking topic of pediatric anticoagulation, touching additionally on recommended laboratory testing, including anti-10A levels, based on her careful reading of peer-reviewed literature. Dr. Phillip is a clinical staff pharmacist at Texas Children's Hospital in Houston, Texas. With a robust background in pharmacy practice, she has been a cornerstone of pediatric care since 2009. She earned her Bachelor of Science in Pharmacy in 2003 and her Master of Science in Pharmacy in 2005 from India before completing her PharmD program in the United States. Dr. Phillip, I'll let you take it from here.
Hello everyone and a happy Pharmacy Week. My name is Blessy Phillip and I'm excited to be here with you today. I'll be discussing direct oral anticoagulations, commonly known as DOAC. As you all know that anticoagulations are the foundation of therapy for venous thromboembolism. The main VTE treatments include your heparin, the unfractionated heparin or your heparin drip, the low molecular weight heparin, the Lovenoxus, the vitamin K antagonist, which is your Coumadin, the direct factor 10A inhibitors, the IV options are bioavailability and Rivaroxaban, and the direct oral anticoagulations, so your DOAC, which is your Rivaroxaban, dabigatran, apexaban, and a few others. The emergence of this direct oral anticoagulants or DOACs for the management of thromboembolic disorders worldwide has resulted in a major shift from oral vitamin K antagonists such as warfarin. A few advantages DOAC have over vitamin K is because the vitamin K antagonist doses are mainly delayed onset of action, they need a parenteral anticoagulations overlap, they have narrow therapeutic window, interaction with dietary vitamin K and numerous drugs, genetic variations in vitamin K antagonist pharmacokinetics that requires a constant monitoring. Today I will be focusing specifically on Rivaroxaban, a key player among the DOAC. We will explore the mechanism of actions, the approved indications of use in pediatrics, and some important consideration in clinical practice. Rivaroxaban. It inactivates both circulating and clot-forming factor 10A. No direct effect on platelet aggregation. Do not need a cofactor antithrombin unlike heparin. Rivaroxaban and dabigatran are the DOACs that's approved for pediatrics. There are a few black box warning. I've just mentioned one of them. The approved pediatric indications are neonates that's greater than 37 weeks of gestational age who has an enteral feed for at least 10 days with a minimum of 2.6 kilos. The few other approved indications for Rivaroxaban, I have noted it. The main ones are that it is used for the active malignancy patients. It's used for the treatment of acute VTE, including cerebral vein and sinus thrombosis. It's used as a prophylactic for VTE in patients with congenital heart diseases after a Fontan procedure. Reduction in risk of a recurrent DVT and PE in patients, continued risk for recurrent VTE after completion of an initial course of anticoagulations. It's also approved for the prophylactic of VTE in patients at the risk of thromboembolic complications. The treatment dosings that we use for Rivaroxaban, I've put it on a table for you. And this will tell that the dosing is usually a fixed dosing based on the patient's weight. So it should be minimum 2.6 kilos to use Rivaroxaban for treatment. It starts with the TID dosing for patients that's less than 12 kilos, and then it goes to a BID dosing and then once daily dosing. For prophylactic dosing, it's also, as I said, fixed dosing based on the patient's weight. It can go from a BID dosing to once daily dosing. Renal dosing. This is one of the important key points we as a pharmacist we should remember when a patient is prescribed for Rivaroxaban. It's a renally dosed drug because it's cleared renally. The onset of action of this drug is 1 to 4 hours. The half-life is about 6 to 8 hours in healthy patients. And as the kidney function worsens, the half-life can increase. So as you've seen, the patient is having a good renal function, but the creatinine clearance is greater than 80. It usually, with half-life, is about 8 hours, and you're pretty good. But if the patient's kidney function is declining, depending on how risky is your procedure, you got to adjust it. Let's say your procedure is a low bleeding risk procedure, then about 2 to 3 times your half-life, which is what, 16 to 24 hours. Let's say if your patient is going to have a high bleeding risk surgery, you're supposed to hold it for 4 to 5 times your half-life, which is around 32 to 40 hours. So that's what this both table says. So technically you do is that you hold the dose depending upon the creatinine clearance. And when you resume after a procedure, let's say if it's a low risk procedure, you can restart it in about 24 hours. But if it's a high risk procedure, you may resume it after 2 to 3 days after the procedure. So Rivaroxaban, it comes in formulations of 1 milligram per ml. It also comes in tablets of 2.5 milligram, 10 milligrams, 15 milligrams, and 20 milligrams. As I said, the bioavailability is 80%. So make sure your patient is able to eat when this medication has been prescribed. Half-life is about 7 to 11 hours. So excretion is excreted mainly renally and some by fecal. Elimination is eliminated about 40% by the urine, some by the oxidative pathway, and the remaining by fecal. Monitoring, we can consider the prolongation of both prothrombin time, which is PT, and activated partial thromboplastin time, or APTT. But on a regular basis, we do not have to keep monitoring when a patient is on Rivaroxaban. As I've mentioned, the specificity, predictability, and the wide therapeutic index of DOAC allows for a fixed dosing without the need of a routine monitoring. So then the question comes into which scenarios we should trigger laboratory monitoring of DOAC. So I would say in urgent conditions like bleeding or thrombosis, the lab results may be needed. In a bleeding patient, it's likely sufficient to have a rapidly available quantitative test that will reliably determine whether a DOAC is present in a measurable quantity or not. So detection of a clinically relevant levels is required in the case that the patient is having a treatment failure or in the setting of a thrombosis. So let's say a patient is having an urgent or emergent invasive procedure, we need a level. And the few other incidences that requires a level that is clinically relevant is indicated in the first box. Whereas if your patient is getting on a regular basis and we just want to make sure the patient is adhering, or in case there's a breakthrough thrombosis, you can just check for a level. And an excessive level is mainly detected in some other situations like the patient has an hemorrhage, there's a changes in the renal function, they have been started on medications that have a high interactions, there is an accidental overdose of the medication in older population, or the patient has any hepatic failures. The laboratory measurement used for Rivaroxaban is basically your anti-10A levels, as it's a 10A inhibitors. If you need to determine if a patient is on a therapy, the drug levels should be what we use to check for is just your anti-10A levels. It is just a suggested level. It doesn't show much specificity, but it at least says to you that if the patient is taking it on a regular basis, the compliance, or if levels are very high, it will at least tell you that the risk of bleeding is much higher. And this slide will explain to you what our lab needs to be ordered and what does it suggest and how it should be interpreted. So, as a pharmacist, we are much worried about drug-drug interactions, and that is where our roles are majorly played. Usually, when a Rivaroxaban is started on a patient, we need to make sure if there's any medication interaction with any other medication the patient has on the patient's profile. Rivaroxaban is a substrate for uh, permeability glycoprotein (PGP) and a flux transporter located in the membranes of the various tissues. And Rivaroxaban is metabolized by your CYP3A inhibitors, which is your hepatic enzymes. Drugs that induces the PGP or the cytokine P3A may decrease the DOAC plasma concentration and increases the risk of thromboembolic events, whereas the drugs that inhibits the PGP or the glycoprotein TA may increase the DOAC concentration and increases your bleeding risk. So this is very important that we look into the MAR to see what kind of medications the patient is taking. Do we need to make any other adjustments on that? So based on these clinical studies, they suggest that if the patient is on a PGPA or cytokine P3 inducers or inhibitors, there's a big chances that can interact with Rivaroxaban. So we would avoid the use of Rivaroxaban in most of the cases. So it's a case-by-case situation. If we can prevent it from starting a different group of drug that doesn't interact with Rivaroxaban, it's better to start the patient on something else. But if it's inevitable to start these agents, then we should be switching them to a different agent. So some of the major drugs that interacts are your barbiturates, your carbamazepines, your phenytoins, rifampin, your HIV medications, your antifungals, and your cyclosporins. So I've given a detailed information of all the drugs that would potentially interact with Rivaroxaban. Now, the next question is that how do I switch to Rivaroxaban? If the patient is on warfarin, you need to start Rivaroxaban when the INR is less than 3. If the patient is on Lovenox, like a low molecular weight heparin, you start DOAC within 0 to 2 hours at the time of the next scheduled dose of the low molecular weight heparin. If the patient is on unfractionated heparin, start DOAC immediately because the half-life of your IV heparin is much less. So start it immediately. When you're switching from Rivaroxaban, stop the DOAC and start warfarin and low molecular weight heparins at the time of the next scheduled dose of DOAC. And sometimes you may have to bridge it. Now, talking about antidote, so Rivaroxaban should be discontinued within 24 to 48 hours, depending on how severe your procedure or how high is your bleeding risk. In some of the instances, if the patient comes with a bleed to your ER or something about the patient is on Rivaroxaban, there is a few antidotes that can be used. In life-threatening bleeding risk, we use an antidote called Adexant Alpha. The average wholesale price of this Andexin alpha, which is an inactive recombinant factor 10A, is about $2.9 per unit. So let's say a patient is around 50 kilos, it's about $7,000. Most of the hospitals may not have that, and it's kind of very expensive to afford that. The other options that we as a pharmacist can suggest is your prothrombin complex concentrate, which is usually 25 to 50 units per kilogram. It is a complex of 4 main factors, 7, 9, 2, and 10. Other one would be your FIBA, which is usually dosed as 50 to 100 units per kilogram. And the main advantages of Adaxavant compared to these are Adaxavant acts within about 2 minutes, and it's a direct factor 10A inhibitors. So, and that's the only one that's approved for the reversal of factor 10A. And hemodialysis, it's not an option for the removal of direct factor 10A inhibitors because of its extensive protein binding. So the next important slide is your patient education. As I've said, if your patients say that they missed an AM dose for a patient that's getting 2 times a day Rivaroxaban, you can tell them they can take it together. Take with food all the time as a result of its bioavailability being 80%. If the patient has a tablet and cannot take it completely, they can crush it and use it. They can give it via the NG or the gastric tubes. It also comes in oral formulations that's liquid, and they can be also mixed with food. Avoid taking any PGPA or strong cytokine P3A inducers or inhibitors concurrently with Rivaroxaban. As I said, it can increase or decrease the concentration of the Rivaroxaban. So renal dose modification is required, and a routine monitoring is not required for patients on Rivaroxaban. NSAIDs are okay to be taken with DOAC compared to other anticoagulations, but we recommend, or most of the studies recommend, not to use it more than 4 days in a week. There is no dietary modifications that's required when you're taking Rivaroxaban. And the biggest advantage, not much overlap or do not need a frequent lab monitoring or INR monitoring. So these are my references, and I'm welcome to answer your questions. You can contact me. I'm a pharmacist at Texas Children's, and I will provide you my phone number and my email for any future questions. Thank you.